etiology, manifestation, convention, code first, use additional code, and in disease classified elsewhere notes. Let's talk about these guys. Certain conditions have both an underlying etiology and multiple body system manifestations. Due to the underlying etiology, for such conditions, the ICD-10-CM has a coding convention that requires the underlying condition to be sequenced first, if applicable, followed by the manifestation, okay? Wherever such a combination exists, there is a use additional code node at the etiology code and a code first node at the manifestation code. These instructional notes indicate the proper sequencing order of the code's etiology followed by manifestation. Okay, so let's try to understand what etiology and what manifestation is. From how I understand it, guys, when you hear the word etiology, it means the origin. For me, that's how I understand it. It is the source or the origin of a manifestation condition. Let's say, for instance, the one that we have discussed last night, dementia is a manifestation of Alzheimer's, and Alzheimer's is the etiology. So that's what the convention is trying to tell us, that in many instances, guys, the coding guidelines will tell you, okay, that there are certain conditions that will direct coders, or will advise coders to also assign an additional code in order for us to bring in or to complete the clinical picture. So that's what these this coding guidelines trying to explain to us. Okay, so again, these conditions, like what the condition that we have, or the diagnosis that we have discussed last night, an Alzheimer's can also manifest dementia, and dementia's manifestation, and Alzheimer's is the etiology. Matter of fact, in the example that we have here, is actually specific to Alzheimer's and dementia. Look here. So again, Alzheimer's is the etiology, the origin or the source, and the dementia is the manifestation. So when you see a code, or when you see a condition that has an etiology, okay, and also as a manifestation, you will ordinarily see this instruction, code first, okay, or use additional code, and in disease classified elsewhere note. So you will see this instruction, okay. Now, to continue, in addition to the notes in the tabular list, these conditions also have a specific alphabetic index entry structure. In the alphabetic index, both conditions are listed together with the etiology code first, followed by manifestation codes in the brackets, and exactly the one I'm showing you here right now. Okay, this is the etiology, and the manifestation is enclosed in brackets. Okay, and when you see that, guys, take note of the sequencing rule. The manifestation has to be coded second to the main code, which is right here is the Alzheimer's. Okay, you cannot have the one in the bracket supersede or coded first before the etiology. And this is huge in the coding guidelines, guys. When we talk about primary diagnosis or principal diagnosis, the primary diagnosis has to come first, has to be coded first, has to be assigned first, because there is there is an impact, or there's an effect to the total reimbursement, to the overall reimbursement to the hospital. The primary diagnosis is essential because the primary diagnosis or the principal diagnosis is one of the factors that enable the system to calculate the whole or the entire reimbursement. And this is the reason why in a AHIMA exam, guys, there will be many questions. And I mean that, many questions asking you, what is the principal diagnosis? what is the primary diagnosis. As a matter of fact, in the AHIMA exam, guys, the primary diagnosis carries the most weight in score, which means that a one whole scenario, okay? Let's say, for instance, the question was about a clinical record or chart, patient chart, and you are asked to analyze, review the chart, and at the end of the at the end of the reviewing the chart, you will be asked, what is the primary diagnosis or what is the principal diagnosis? And this is the reason why in the coding conventions, guys, um, don't be surprised if there is a strong emphasis on determining the primary diagnosis or getting the right sequencing because, like I said, it is very, very important even in the actual clinical setting. Okay. Now let's continue. Code first and use additional code nodes are also used as sequencing rules. Okay. Obviously, code first is a sequencing rule, or use additional code is a sequencing rule. In the classification for certain codes that are not part of an etiology manifestation combination. Okay. So I'd like you to really digest this, guys, as much as you can, because this rule, the code first and use additional code, like I said, are conventions, are rules that advise coders to observe or wanted to make sure that coders will be able to determine which code comes first and which code comes second. Okay, let's continue. Now, remember last night, guys, we had a good discussion about width, and this is exactly what this coding convention is about. Let's read it. The word with or in should be interpreted to mean associated with or due to when it appears in a code title, the alphabetic index, or an instructional node in the tabular list. The classification presumes a causal relationship, okay, between the two conditions linked by these terms in the alphabetic index or tabular list. These conditions should be coded as related even in the absence of provider documentation explicitly linking them, unless the documentation clearly states the conditions are unrelated or when another guideline exists that specifically requires a documented linkage between two conditions. Examples, sepsis, guideline for acute organ dysfunction that is not clearly associated with the sepsis. So I will talk about this later on, guys, when we get to infection. I will have a good a good discussion about this. For conditions not specifically linked by these relational terms in the classification or when a guideline requires that a linkage between two conditions be explicitly documented, provider documentation must link the conditions in order to code them as related. Okay, so it's really a long narrative here, but let me try to simplify this rule right here, okay? What you need to remember the most from that, what we have read, guys, is when you see a condition, okay? There are conditions, by the way, there are conditions in the coding book, okay, that when you reference that condition or that disease, that condition will have a specific link word, which we have seen in diabetes, right? So when you go to diabetes, last night we tried to do that, guys. We wanted diabetes, and immediately under the word with, you see other conditions that have an assumed relationship with diabetes. Like, let me write this down again. And this is a good example, guys, of these link word that needs to be observed all the time. Okay? You went to diabetes, you see all these other terms, right? We now know what these terms are that are enclosed in parentheses. Do you guys remember what these terms are? And you see the code here, E11.9, right? So these are non-essential modifiers. We talked about this last night. Now, immediately under the word diabetes is the word with, right? And you have all these arthropathy, right? What else? Autonomic, uh, neuropathy. I'm just trying to remember on top of my head, guys. You have uh, CKD. What else? You have foot ulcer. Okay. You have and many others. Okay. Now, what's the point here? The point is that again, this word with here is a very important link word that connects CKD, autonomic neuropathy, arthropathy, foot ulcer directly to diabetes. What that means, guys, we also have peripheral neuropathy somewhere here. Peripheral neuropathy, peripheral angiopathy. And what this means, guys, okay, from what we read in the coding guidelines, that even if the doctor did not intentionally link these two conditions, this angiopathy to diabetes, you are to assign the combination code that you see right next to this condition here. Let's try to put all these um, the codes for these guys here. I don't exactly remember what the code for arthropathy, but you guys can look it up. For CKD, you see E11.9, right? Foot ulcer, I think E11621. Okay, peripheral neuropathy is E1142, and this one is E1151. Okay, can you guys look it up? What is the code for this arthropathy and this one? I think this one is E1143. What about arthropathy? What is the code for diabetic arthropathy? Can you guys go to diabetes so we can determine what the code is? E11618. Thank you, Rodi. Okay, E11618. And am I correct with this? E1143. Yeah. Maybe it's the wrong word, huh? Oh, I'm correct. Okay, so now what's the whole point of these discussion, guys? The reason why I'm telling you this is that because when you see doctors' documentation saying, "Hey, patient has diabetes," okay, and presents with something else, blah 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 blah, right? And somewhere in the documentation, you also see doctor says patient also has um, foot ulcer. Okay, patient also has foot ulcer. Okay, the whole point of these is that in the documentation, the doctor did not link diabetes to foot ulcer, but that does not prevent you guys to use the combination code. Um, to use the combination code because it doesn't really matter whether the doctor linked it or not, did not link it. You still have to connect diabetes with foot ulcer. which means, okay, which now gives you the code instead of assigning this E11.9. Oh, I meant fault also, right? Instead of assigning E11.9 or separate code, the fault also, you are not to assign the code E11621. Okay? So that's the whole point. That's the key takeaway there. You are to automatically connect these two conditions together, even in the absence of doctors' explicit documentation trying to connect these two conditions together. Is that clear, everyone? Yeah? Um, Now, let me explain to you guys, okay? Coders who do not know this rule or this, this whole guideline, when they assign code for, for scenarios like this, they would go like E11.9 and then assign whatever foot ulcer code is. I think it's L97 for 9 something. Okay? This is how coders who did not know this or did not learn this, okay? But now that we know the rule, we are no longer using this, but as we are to assign a code for this scenario, we are now to assign E11 621 and then L97 something, right? Always use the combination code because like I said, this word with here connects these two conditions automatically. Any question, guys?
Sir Ellie, how can
Yes,
we know, like what you mentioned earlier, if the
yes,
coder doesn't know, usually they would separate the coding for diabetic and then for the foot ulcer.
right.
But my question is, of course, as a coder and doesn't have a background of medical, how
Mhm.
can we really know that these are interlinked, especially when the doctor didn't say with, you know?
You don't have to, like I said, thank you, Rodi, for that question. As soon as you see diabetes and foot ulcer in the chart in the patient's record, you are automatically to assign this code. That's what I'm trying to say here is that you don't need any other instruction like hey should I query the provider, should I ask the doctor whether these two conditions are linked together. No, you don't do that because what we're basing our decision from is this right here, because when you go to the book, remember, if you go to the book, guys, diabetes, you go to the book, this is how you exactly see it. You see the diabetes here and you see the word with. And this word with here is an instruction itself that you don't need to wait for the provider to confirm it. As soon as you see these two conditions together, you got to assign the combination code. Does that answer the question, Rodi?
Yeah. So what in summary, it's like when you know that the patient has diabetic, of course, there's a lot of complication.
Right.
What comes with it, we just combine it, not
That's
separate.
absolutely correct.
Got it. Got it. Thank you.
Absolutely correct. So that is a very important question because um, here is why coders need to understand that guideline, and you really have to put that in practice religiously. Okay, this is why it is important. There is a there is a certain reimbursement model right now. Okay, um, I'm going to talk about the other reimbursement model, like how hospitals are paid later on. But let me give you a specific example why using the combination code is hugely important. In your coding practice and in your coding process. Okay, there is a a reimbursement model. Let me erase this right here. Okay, which is called risk adjustment. Risk adjustment. Okay. Now, this risk adjustment model, guys, it banks on the the capture of all these chronic conditions that a patient may have. Because this risk adjustment reimbursement model, what I'm talking about risk adjustment payment model, guys, is that this is a payment model that is mandated or enforced by Medicare to medical practices, okay, to physician physician medical groups. They mandate physicians, probably mandate is a strong word, not man, they encourage, okay, they encourage doctors, physicians to capture all the chronic conditions of the patient because this payment model, the goal for this payment model is to be able to determine how sick this certain patient population, okay, because if how the payment is calculated for each individual, okay, is based on how many chronic conditions that a patient may have. Let's say, for example, I'm talking about of the age group 65 and older. Those are Medicare population, okay. Loven is asking, does this combination code only apply to diabetes? Answer is no, it's not just diabetes, okay? It's applicable to any condition that has, again, the word with right here. But diabetes is a very, very good example because there are many conditions that are related or connected to diabetes. Now, let me continue with what I'm trying to explain. So the objective of this reimbursement model is to encourage doctors to be able to report, capture all the chronic conditions that the patient may have. Because depending on how sick or how well the patient is, the payment to the provider is actually based on, okay, is based on the provider's or doctor's ability to record all these chronic conditions. Okay. Now, if they report all these chronic conditions, they submit this information to Medicare. The sicker the patient, the higher the reimbursement is awarded or rewarded to the provider. So that's how it goes. Now, if you're the coder and you are part of that reimbursement system, we call it risk adjustment or Medicare Advantage. Okay. Now, imagine each condition here has what we call a score, a risk adjustment score. Okay. Let's take, for instance, this diabetes, plain diabetes without using the combination code will have, let me just give you a hypothetical score, okay? Let's say, for example, the coder is not a trained coder and and you see a patient who has diabetes, has foot ulcer, who has COPD, who has heart failure, okay? The the E11.9 will have a score of point, from what I recall, okay, 0.105. Okay, this is a risk score. Now I'm telling you this information early on, guys, for you to understand why it is very important that you understand the concept of combination code. Okay, now if you assign the code E11621, look at the 621. The score for that is 0.305. It tripled, right? It tripled, like 0.105 and 0.305. It's It's a big difference, right? Arthur saying, by saying combination code, you mean the codes listed? Yes, Arthur, when I say combination code is this, because you already have combined foot ulcer with diabetes. Look here, guys. 0.105, the reimbursement hypothetically, okay, I'm just talking of the ballpark, okay? Each 0.1, 0.1 gets almost $900. Okay? Imagine if you assign the code E11.9 versus E11621, how much reimbursement or payment to the provider you are missing, you're losing. You guys don't understand what I'm saying here? And this is really, really important. That's why this word with here is a very powerful link word because it does impact your reimbursement. Does that make sense, guys? And imagine if patient, I'm only talking about diabetes here. What if a patient also has, say, patient has COPD, J44.9. Patient has heart failure, I50.9. Okay? The RAP score for that, from on top of my head, 0.335. This one is 0.3, think 321. Okay? And at the end of the day, they add them all up, and then from the total, there are some more adjustments that are done, and then from the total, they will multiply that to this one right here, $900, and that's the total cost or the total reimbursement that is awarded to the provider for taking care of the patient, and all and uh, the provider needs to do, okay? All the provider needs to do is to report it, to record it. If patient is diabetes and the patient is on metformin, the provider just need to report in this documentation once a year. Patient has diabetes, okay, and now on metformin. That a patient and the doctor would go further with patient is advised to watch his diet or her diet. That's it. You have already reported the condition. Imagine if the coder does not know this, guys, how much reimbursement that doctor is losing if the provider is not, if the coder is not knowledgeable about this coding guidelines. Okay. So this is exactly the reason why uh the following the coding guidelines, guys, is a matter of, say, really a life and death of the practice. Okay? The reason why small practice don't grow, they remain small, is that because they don't have trained coders. They don't have trained people like us who study this. Okay? They need to have a coder who is very knowledgeable in the coding guidelines, because the coding guidelines is not just there to mandate it, but also to provide the proper reimbursement for all these medical practices. Okay.